My next talk is about injection drug users and hepatitis C in injection drug users. So we had yesterday already some presentations on this topic, and we had some results from some clinical trials concerning injection drug users, and I will start first there about idea why it's so important. So injecting drug users, it's so-called super spreaders. So they're people who really spread infection because they have really high risk to contracting HIV, hepatitis B, and hepatitis C from sharing needles and other equipment, and contaminated, of course, with the body fluids. And because there's a compulsive nature of this addiction, it's really the person who spread infection with really high speed. So what about transmission epidemiology? I already mentioned yesterday the results of the trial was conducted in Germany with some questionnaires asking people how could we transmit infection, and many of them, the people who inject in every day since many years drug, say it's only via syringes because it's contaminated. But in contrast to HIV, the hepatitis C can survive outside of the human body in a certain circumstance for many days, and even in dried bloods and surfaces, in filters that used, or cigarette filters that used many drug abused people to particulates from drug solution, or even longer in such condition like barrel or the syringe itself. So it's just to get an idea how long people need to acquire some infection. So it's this trial that's conducted for many years already that show the months to conducting to acquire some infection for injecting drug use. So you see after 5 years, about 80% of people acquired hepatitis C infection. This is this pretty same number of infected people we have in many high and middle income countries. For HIV, you have about 20%, and for hepatitis B, it's pretty the same as the hepatitis C, but it depends, of course, on the prevalence of hepatitis B in different regions. This is a pretty old map that's from OECD concerning intravenous drug transmission in HIV, not in HCV patients. I see the most country that's really involved in this epidemic is in Eastern Central European countries, the former Soviet Union, and of course some South European countries like Spain and Portugal. That's what is important. The infection drug use is really major risk factors for HCV epidemic in many high and middle income, and in middle income countries as well. And the people who inject drug use account 50 to 80% of hepatitis C infection. Hepatitis C treatment uptake on interferon-containing all treatment has been low, particularly in this group patient, because of many of the people afraid of some side effects, and it was a problem, it's a barrier to treat this patient. And despite the similar hepatitis C outcome on interferon-containing regimen in some new trials, that people who are active on drug abuse was excluded from the DRE program in clinical trials. You see the prevalence of hepatitis C in people who are injecting drugs as a worldwide pretty the same. It doesn't matter if it's in Russia, in Soviet Union, former Soviet Union, or in Western Europe, or in US, you see the pretty the same number. It's about 60–80% of prevalence of hepatitis C in people who are injecting drugs. This is German data from Robert Koch Institute, and in C we have 5,000 new cases in year approximately, and 3,500 is as unknown, so it was information from physicians. This is unknown risk, and from known risk we see that 87% is intravenous drug users. So in Germany they have the same situation as in other countries, and only 6% is MSM, and then followed by dialysis patient from past and blood products, and very small number of children to get it from during pregnancy. In Germany, we have different data to prevalence of hepatitis C, and it's between 40 and 90% even. We have a last data from a study that performed in many German cities like Berlin and Frankfurt as well, and we have very high prevalence, about 60 to 70% of hepatitis C in this population in the street. It was really people not obviously in opioid substitution, but the people on a street drug user, so a very high prevalence. And in new cases of hepatitis C is about 80% due to intravenous drug use. About 30% of all people who are on opioid substitution in Germany have a problem with alcohol, but it's very important for the liver disease, of course. What is in other countries? For example, in USA, somebody have been at the CROI last year, now this presentation from CDC about a case of state Indiana, and this is this outbreak of new population for US, so it's white people in a small cities in this small state Indiana who get prescribed opiates from a doctors. They're very short opiates like oxycodone, and they use it many times a day, till 10, 20, 15 times injection per day per patient. And in this state Indiana, it's no program for syringes exchange, it's no methadone program in state Indiana. It was really a big outbreak, and it was investigated by CDC, and it was presentation at the last CROI meeting. What is the idea about Eastern Europe? It's some data for a few years given by my colleague from Ukraine, and it sees the highest prevalence of hepatitis C was in a group of patients who have HIV and intravenous drug users, about 80%, and the people who have HIV and tuberculosis, about more than 80%. It is a small trial. I found it for some years. It was a really small cohort trial looking for HPV and HCV prevalence in Ukraine in different population group and different risk group, and I see the people who have intravenous, who are using drugs intravenously, and people with HIV is the highest prevalence of hepatitis C, which is typical for epidemic in Ukraine, probably not right now, but for a few years, because now we heard about more sexual transmitted HIV and less and via drugs. What is most important for me, we discussed it yesterday a long time in the evening about opioid substitution. Is it important? Is it not important? Is it a part of harm reduction? Yes, is it part of harm reduction? It's a very important part. So injection drug user hepatitis suffer from different health condition problems. It's some psychiatric diseases, it's HIV, it's multiple healthcare problems, including, of course, hepatitis C, and it's critical to treat these people to reduce risky behavior and to increase the chance, decrease in chance of transmitted of hepatitis C. The most important to understand what a hypothesis is. So hypothesis is an heroin opiate addiction is a disease. Is a chronic disease, is a metabolic disease of the brain resulting behavior of a drug hunger when a drug self-administration, despite of clear negative consequences for person themselves and for other person. So people who use drugs, they know it's forbidden, they know this is criminal, they know they have no positive consequences for a person themselves, but they do it because they are ill. And the heroin addiction is not simply criminal behavior due to some antisocial personality or something like this. It's a disease, and it's a personal disorder. The goals of rational specific pharmacotherapy in the addiction, and it's prevent of withdrawal syndrome, it's reduce drug craving, it's normalize a psychological function of despite of the drug use, and a targeted treatment with the agent who have a really specific action with the receptor and physiological system in the body. This is some difference because many say the methadone is the same opiate like heroin, as it doesn't matter if the people addict on methadone and heroin, it is not the same. The first is most important, the route of administration. In heroin is administered intravenously, and methadone could be administered oral. So we exclude the way of transmission of hepatitis B, hepatitis C, and HIV because oral administration. The most important, of course, it is not on the slide because it's not medical, it's methadone is legal. This is more important if we talk about criminality, about mafia. So methadone is legal to prescribe by doctors. The people don't need money to buy it. So it's one of the most important points. The onset of action is in heroin is immediately. In methadone, you have there about 30 minutes the onset of action, and the duration is much more longer than heroin. So we have, in contrast to heroin, that have action of only for 3 to 5, 6 hours. We have 24 to 36 hours. The euphoria exists not in methadone. As methadone, it's not really a drug that gives some kick for patient. It's something a patient misses kick if they get methadone. It's true. And with withdrawal syndromes starting in a heroin case after 3 to 4 hours, and in methadone only after 24 hours. That's just to story. And methadone started in 1969 in US, and the special institution for young people between 6 and 21, and then in 71 it was integrated with adolescent development program as from a community-based facilities, was integrated to clinics, to Cornell New York University Hospital, and then continued to Rockefeller University. And then 33 was creation of the second separate facility for adult patients, and it was integrated in a hospital. That's started with Professor Dole. This is interesting data to the starting of HIV epidemics, the data from 83, 84, and you see the people who at that time were starting HIV epidemic were testing for HIV-1 antibody. 50 to 60% of heroin streak addicted person in US was already positive for HIV before starting epidemic, at the starting of the epidemic. And the people who were involved until 1978 to methadone maintenance program who get already opioid substitution and don't use intravenous drug, the prevalence was about 9%. I think that's really impressive to show what is the reason to give methadone. What is about new medication? So they get yesterday some presentation concerning intravenous drug use, a talk on the many satellites from pharmaceutical companies about some advantages of their treatments. Just shortly, we have higher SVR rate even compared to interferon treatment. We have easy treatment with 1 tablet, sometimes 2 or 3 tablets a day. We have no interaction with methadone and buprenorphine. That's most important for opioid treatment. So we didn't have any directly interaction of interferon treatment as well with methadone, but we have some symptoms of interferon treatment that a person confused with some symptoms of drug addiction or some symptoms of abstinence. So we need to give more methadone in that cases and so on. So they have this problem. We don't have this problem right now with new DAAs. And the treatment interruption is less than 1% because of adverse events, in all clinical trials. We have a short duration of treatment. Pretty all treatment option that we have right now is 12 weeks, maximum 12 weeks, even 8 weeks treatment. And we have less laboratory tests. The actual laboratory tests during treatment is only needed for compliance or to motivate patient to look for hepatitis C PCR during treatment is not necessary anymore. So this is some clinical trials last time who regarding patients who injecting drugs on opioid treatment. This is CH Costar treatment of Grazoprevir Elbasvir. You see the same result that you see all other patient group. So it's even not more really interesting to show with diagrams because we have only 96 to 100%. All group you see only 60% was in genotype 6 patient, but it's no experience at all in this group of patients. So you see the same results in the people who get substitution like we have in other people. So it's really interesting data about adherence in this trial. You see then both, it was a design trial that the first patient get medication and placebo and on the switch arm, and you see there people who get more than 79 doses, so it was a really good compliance. You see more than 80% in both groups get more than 80% of dosage. So it's shows this is really, really perfect compliance in a patient on opioid substitution therapy, and I just could confirm it from my own experience. It's very perfect compliance. Even say the people who get in our practice methadone substitution or buprenorphine is more compliant than the people without drug addiction because they have better control and compliance in the case. And the conclusion of this trial was a high efficacy of genotype 1 and genotype 4 patients with Elbasvir, Cazaprevir, and a very good safety profile, highly studied medication adherence, and data demonstrate that hepatitis C treatment among the subject who injecting drugs or on opioid and agonist therapy is the same in other people. Trial from this is a small trial, there's 38 patients that achieve 97% of efficacy endpoint, so achieve S4, SVR. So it's only one patient in this trial permanently discontinued treatment because of some side effects, but not related to drug. It's the same result with the C and other patient groups. So again, what about real life data? Because we could say, okay, in clinical trial, we have a special group of patients. It's the best opioid substitute patient. It's not what we every day have. So this is the data from German hepatitis C register concerning only one therapy regimen with obmetazvir, paritaprevir, dazapavir, and riba. And you have the compare of different patient group. Of one of them was intravenous drug users, and you see the data was absolutely comparable with main population. This is 500 patients. This was whole population of all who get in this register. It's just a cohort study. And we see the 30 patient from intravenous drug user was 100% SVR in real life data. The same results, it just unfortunately could not see well. This is in poster from Pavel, but the same results, very high efficacy also in a patient receiving opioid substitution treatment. What about drug interactions between methadone and buprenorphine? We see not really a relevant drug interaction between this medication. You could look in something like Charles from Liverpool. You could look on buprenorphine and all treatment regimens that we have. We see all green and sometimes yellow, but it's not really relevant, and it is very high safety profile and very good interaction profile between methadone, buprenorphine, and DRAs. And our own experience, the opioid substitution is the best predictor for successful treatment. It shows high compliance, a very low reinfection rate, and high motivation. And from experience, special advice is to treat patient on opioid substitution treatment. In difficult cases, in difficult compliant cases, we could even combine administration of methadone, buprenorphine at the same days with administration of DRAs, and it has very good control and adherence. And intravenous drug use and alcohol abuse has generally no influence on the treatment outcome directly because there's no drug-drug interactions between heroin and alcohol and DRAs. It's only for individuals who have really non-controlled high-risk behavior, who are non-compliant, who are not coming to a practice to get medication, that is a problem. So in only this case, it's a treatment, it's not recommended, so we're waiting to try to stabilize patient and then starting treatment. And so I told before, it's now significant interaction between all DRAs and riba with methadone and buprenorphine, and only in patients with decompensated liver cirrhosis we could be careful looking for dosage interactions. And as summary, a screen for hepatitis C for all patients with IVDU. The treatment is really extremely important, not for a person by itself, but epidemiological and public health of reason. Opioid substitution treatment is one of the optimal background for successful hepatitis C treatment in this group of patients. And the treatment duration, frequency and blood tests and doses is absolutely the same than the people in non-IVDUs. And interferon-free treatment is very safe, well tolerated, and the most important requirements, of course, is the compliance of patient. And just at the end, some that one doctors and psychiatrists are now pioneers of the substitution therapy say that people say we have no policy treating addiction is not true. We have the policy. It's that which shouldn't treat, but not very well. And unfortunately, it's true for many, many countries still now.